My name is Dan Zlotalo. I'm going to be talking to you today about radial longitudinal deficiency, to treat or not to treat. That is the question. So just some background, radial dysplasia includes thumb dysplasia, and it's a broad spectrum of presentation. And as Mary Beth Izaki says, it's just the tip of the iceberg. Generally, when you see radial dysplasia, you're going to see other things as well. In the radial and ulnar development, there's a progressive reduction of fibroblast growth factor, leading to progressive failure formation of the radial-sided structures. If you look at ulnar-sided growth restriction, there's progressive reduction of sonic hedgehog. So these are different growth factors that lead to different phenotypes. Associated conditions include Holt-Oram syndrome and Vactral association, as well as Fanconi's pancytopenia and TAR, thrombocytopenia absent radius. Here's an example of Holt-Oram, and you can see this familial tracing here with mom and the daughter both having radial dysplasia. Thrombocytopenia absent radius, it's important to note that TARs have thumbs. They may be flat and they may be abnormal, but they do preserve thumbs. Fanconi anemia or Fanconi pancytopenia is a big problem, and this is one of the few times that we can actually save a life. These children should be placed on the transplant list. If you look at their chromosomes, they are fragile and they reconnect. And as they reconnect, they tend to get myelodysplasias and acute non-lymphocytic leukemia. These can only be cured by bone marrow transplantation if diagnosed in time. And so they should get on the transplant list at a very young age. Vactral association has vertebral anomalies, imperforate anus, cardiac issues, tracheoesophageal fistulas, renal issues, and also limb deformities, hence the acronym. When we look at radial deficiency, there's a progression of deficiencies. And this not only affects the bones, but we tend to overlook the effect it has on the muscles, the nerve, and the arteries as well. The vein include classification looks something like this. You have a hypoplastic or slightly short radius on A. B shows a more absent radius. C, now you're missing the distal half of the radius at least, and D, you have a completely absent radius. And put another way, from Boston Children's, you have this nice schematic here, which shows the progressive absence or progressive dysplasia of the radius. So the treatment goals are to improve function and appearance, improve wrist stability on the form, and maintenance of wrist and finger motion. Reconstruction of thumb deficiency is also part of the whole treatment algorithm. We did a study looking at combined clinic and home-based therapeutic approach for the treatment of bilateral radial deficiency in a child with Holt-Oram syndrome. And while this is a case report, it's important to note the functional achievement that the functional gains we were able to achieve. Lori Ragney was one of the therapists involved and really spearheaded this effort. So when we look at this child's range of motion, you can see at phase 1, resting posture and radial deviation over here was 80 degrees. And as phase 2, and we went on to pulsations, you can see that we gained 80 degrees of radial deviation, so of ulnar deviation. The orthosis treatment the goals were to improve range of motion, maintain the range of motion, phase 2, then phase 3 was the pulsation protocol. And you can see that using a combination of splints and therapy, we're able to not only achieve a good position of the wrist, but also to maintain it over time. And this is the picture I showed you of one of the treatment goals. And you can see this child never had surgery. This had a very dedicated parent and a very sophisticated, intelligent, and capable therapist. And that combination leads to something like this. And with long-term splinting, which the mother will be able to do, we will have an excellent result long-term, most likely. So when we compare surgical treatment to non-operative management in this article by Cotwall, Now, keep in mind, they did not have as rigorous a therapy protocol necessarily as we had in our case report, but they showed much better results. And although both groups were subjectively pain-free and rated the limb cosmetically poor, the untreated group was more dissatisfied with the appearance of the limb. And therefore, they concluded that surgical treatment was associated with significantly improved hand-forearm angles and hand-forearm positions when compared to non-operative treatment, and that had a strong inverse linear relationship with functional scores. What does that mean? The child was able to have better function and was happier with the limb with surgery than with non-operative treatment. But I would challenge you, as in our case report, that is as good as any surgical outcome. The entry-level surgery is going to be the bilobe flap, so-called Mickey Mouse flap. It used to be dorsal approach, now it's a volar flap, as described by Scott Oishi and Mary Beth Izaki. And this article by Carly Buyerman, looking at ulnar growth patterns after soft tissue release with the bilobe flap and radial longitudinal deficiency, they found, as you can see on this chart, that soft tissue releases with the bilobe flap did not affect the ulnar growth in the way that traditional centralization procedures can. And this procedure has previously been shown to retain motion and have similar recurrence rates to formal centralizations. So that begs the question, if therapy can do it and a small soft tissue release can do it, then why pursue more invasive surgical plans? So the more invasive plans look like this. There's centralization and radialization. Centralization shown in A and B, and radialization on C and D. Ulnarization is when you take the wrist and completely put it on the far side of the ulna. The problem with ulnarization, it creates a very prominent ulnar head, which most patients do not like. We have done that operation and have stopped doing it. When Claire Mansky looked at the effect of soft tissue distraction on deformity recurrence, that was after centralization for radial longitudinal deficiency, they found that pre-centralization distraction with a ring fixator facilitated a tensionless centralization, so it made it easier to do, and provided excellent early alignment. But when they looked at the long term, there was a greater degree of radial deviation and volar subluxation of the carpus in patients treated with ring fixator prior to centralization. In addition, it remained unclear if distraction was protective of the physids since their growth was about the same. These data for them have led to a re-examination of their protocols and preferred treatment strategies. They still do centralizations, and they believe that this benefits their patients, as was shown in the Cotwall study. And they continue to use pre-centralization distraction because it facilitates the centralization procedure, even though results showed that they get better long-term correction if they don't do distraction, which is really interesting, and it probably has to do with the damage they're doing to the wrist with the notching. In this study by Lindley Wall, looking at preferred treatment as a survey, when you look at a type 1 radius, most doctors preferred observation. When you look at type 2 radius, then radial lengthening was most common, although there was a variation in treatment, as you can see. In type 3 and 4 radius, after initial stretching and orthosis wear, most people went for soft tissue release of the bilobe flap. However, the second most popular was centralization. Radialization was still up there, and observation was there as well at 3%. When they looked at which type of external fixator to use, most people, particularly if they were orthopedic surgeons, chose a unilateral fixator rather than a ring fixator. Now, things can get pretty complicated beyond centralization and radialization, and that is vascularized metatarsal phalangeal joint transfer in this classic article by Simo Vilke. And here he uses distraction to get it out to length and then places a second toe metatarsal phalangeal joint to create a second articulation rather than just the carpus with the ulna. Now there's the MTP joint with the wrist as well. And long-term results he showed were excellent. And you can see this child. Their hand does not look normal, but as studies have pointed out, patients also like having an improvement, even though it doesn't look like their typical hand. Now you can get further afield with a vascularized proximal fibular epiphyseal transfer. And this is for type 3 Baden-Klug types, and they had 4 cases of this. And here you see a child pre-op and after the external fixator is applied, and they do the external fixation to get the same thing, to get more length. Here they are harvesting the proximal part of the fibula with the epiphysis. And here it is in terms of the surgical outcome. And you can see that all the way on the far left, sorry, on the far right, their outcome is amazing. This is a fairly controversial thing to do because it could potentially affect the knee, but there's no question that the outcome is excellent in these 4 patients. And here's an example, and look at pronation, supination, flexion, extension of the wrist, and this is pretty remarkable outcome, I think. Again, just more data to show how amazing their outcome was. Now, whenever we think about radial deficiency, as I said earlier, we have to think about the association between radial deficiency and thumb hypoplasia. And these things tend to correlate. The more severe the radial hypoplasia, the more severe the thumb hypoplasia as well. When we look at treatment, this has been fairly well established in the Western Hemisphere, although in Asia, there is a cultural preference for 5 digits, and therefore more reconstructive procedures are performed. But generally speaking, we're looking at pulsization for anything 3B and above, and reconstruction for 3A and below. But I think that this ulnar-sided grasp question is overlooked. And when you have a child, for example, with an absent thumb and an index finger with decreased motion, so their index finger is not going to make a good thumb, and the child utilizes ulnar prehension, so they use their ulnar-sided fingers for grasp, would you perform a pulsization? And if you look, about 54% of physicians surveyed said no, they would not offer the family pulsization. But an alarming number of surgeons did offer pulsization to those patients. And what's remarkable is that in our hands, none of those thumbs are usable. Now, another survey question is, does ulnar prehension or ulnar-sided preference for the grasp change how you treat the wrist and the forearm? And again, this was about 50-50. So ulnar-sided grasp did make an impact on the physician's choice, and therefore what the family was offered. But I think in my hands, this is not even a question. If their index finger is not mobile, and they use their pinky and their ring finger for grasp, I do not pulsize those hands. So what do I do really? I let the family decide. So when you're looking at radial deficiency, there are so many choices that I think for me, I give them the options. I'm not going to do a proximal fibular transfer because I just don't know how to do it. But I will present that option, and I will steer them towards somebody who could do that operation. We do perform the Wilke procedure, and I think that that's a reasonable procedure to perform, but we've only had a few takers on that. So I think everything is on the table. You can offer the family everything and give them the information that they need to make the choice for their child. And just remember also that we are very good at pushing the boulder up the hill, right? But we don't follow through on keeping it there. And the analogy is like braces, right? Braces are surgery, and a retainer is the splinting until maturity. We cannot expect a child to be corrected and then maintain that correction through their entire childhood without maintenance splinting. And so I would challenge every person on this call that if they're going to do these operations, because of the high recurrence rate, that splinting should be part of the explanation of what the postoperative protocol should be until skeletal maturity. And I think that that is going to improve our outcomes. Thank you very much.